this year's Mental Health Day topic. Over to you, sir.
Good morning, everyone. Director in IMH, Dr. Shamli Ratnayaka, my dear consultants, colleagues, consultant community physician of the Ministry of Health, Dr. Yamna Lavale. We are also fortunate to have two former directors, Dr. Jayana Mendis and Dr. Damika Vijay Singh here with us. And ladies and gentlemen, first of all, I wish you all a happy Mental Health Day, and also take this opportunity to wish my senior colleague and dear friend, Dr. Pushpa Ranasinghe, a very happy birthday. And as somebody said, Madam, you are born to serve mental health, and so wish you many more years of service to mental health in Sri Lanka. So, I prepared a speech in English. It's too late to change track now. It's a medical and nursing audience. And before going to the theme, I thought I would reflect upon the history, little bit on the history of mental health in Sri Lanka. I must apologize to my colleagues who were there at my presidential address 2 months ago. I'm repeating some of the slides. You can use the time to check your phones. Those who fail to learn from history are doomed to repeat it, said Sir Winston Churchill. It is well to go back to history and reflect upon history of this mental health institute. The British colonial government brought their concepts of mental health care and psychiatry to Asia. Unfortunately, in the case of Ceylon, things were much worse than our South Asian neighbors. They said in the case of Ceylon, these asylums were crowded, dirty, violent human warehouses, or factories, warehouses. That the idea of treatment as we know it was impossible. This was how one of the British psychiatrists described mental health services in Sri Lanka. Angoda was not the first mental hospital. The lunatic asylum in Boraya was started in 1847. It existed in 1861. Very soon it became overcrowded and many of the mentally ill were in jails. The colonial government at that time had little interest in improving mental health. But fortunately, there was Mr. Vambeck, J. Vambeck, who was the assistant surgeon in charge. Probably would have been surgeon, that's why he called Mr. With a conscious attempt to improve care, but unfortunately the treatment methods were very primitive. Cold bloods, bleeding, health tonics, and the sedatives were cannabis and opioids. But it is interesting to note, today we talk about work and mental health. Even way back in the 1850s and 1860s, the then medical superintendent understood the importance of work for mental health patients. And he introduced occupational therapy, gardening, cooking, making choir mats, started an industrial fund out of the profits, started recreational activities for patients, travel money for discharge patients, which is still used, was started by Mr. Vambeck way back in the 1850s. And by 1906, the industrial fund had over 20,000 rupees. Those days, a rupee was a very powerful currency, not like these days, right? So 20,000 rupees was quite a handsome sum. So, unfortunately, the government auditor did not like this fund. Did not approve. It was not within the regulations of the government. In 1907, the industrial fund was abolished. Mr. Vambeck was sent to Daphna, and that ended the useful occupational therapy at Boraya. It took many years to restart it. Many years to restart it. Then they moved the asylum to Cinnamon Gardens in 1885, very short-sighted measure, it was a very small site. It became overcrowded. Of course, there was a British doctor, medical doctor, Dr. Plaxton, to supervise it. But there was no real change in the treatment methods. But he did try to stop violence by attendance. This is something that I like to. We still haven't completely eradicated violence. It's still there to some extent, or to very, maybe underground level, but it's still there. So this is the Cinnamon Gardens Asylum now. I'm sure all of you would have gone there. It's a nice shopping arcade. And then they built a brand new Angoda Mental Hospital in 1926. And the capacity of 1,728 beds, 6 three-story blocks, 18 wards, and a very spacious premises. So this was built with great hope, but within the first year, the new asylum became full. By 1930, the asylum was overcrowded. Large numbers of patients were dying from TB and dysentery. In fact, in 1930, 404 patients died. And the other problem was criminals with mental illness were kept with the normal patients. In 1937, Professor Edward Mapata from the Marsden Hospital in London came to study the mental health system in Sri Lanka, or Synodis it was called. He was appalled by the state of Angoda Hospital. I showed what he talked about earlier. And the mental health care had deteriorated from the time of Borrella. So he proposed separate wards for short-term and medium-stay patients. This was in 1937, and we have achieved it now. But there are some who want to go back and have unified wards even now. You know, so there are a lot of arguments. Still we are still having arguments. So the psychiatric clinic at the General Hospital was started. A separate patient institute was started to house the court patients. Training of doctors, social workers and occupational therapists were recommended. And he recommended changes to the lunacy ordinance. He recommended establishment of occupational and recreational activities, employment of patients, canteen, carpentry, weaving, printing, with profits going to benefit patients. So you can see the work that work benefits mental health was known long time ago. And of course, only some developments occurred because of the background in the Second World War. Then, as an effect of the Mapata report, in 1938, 3 doctors were sent to UK to train in psychiatry, and I think all of them returned. And in 1943, the outpatient unit was started in Colombo, and the modern and the 25-bed hospital was opened at the Colombo General Hospital. And Mapata, there was a notorious ward in Angoda called the noisy ward, where all the difficult patients were housed. Maybe like a primitive HDU. And Mapata wanted it closed, but they never closed it. But the Japanese bombed Angoda in the Second World War, and fortunately or unfortunately, they bombed out the noisy ward, killing 10 patients and injured 70. But Angoda survived, as it survived many other attempts to close it. So then by the 1940s and 60s, insulin shock therapy came into vogue. The Serlete and Benny found ECT. Antipsychotics came into effect like chlorpromazine, and psychotherapy, occupational therapy, and recreational activities. Then the specialized clinics for children and adolescents and neurotic illnesses were started, and more people were discharged from the mental hospital. But Angoda continued to be overcrowded. So then we had the Vikramasinghe Commission. There are 2 Vikramasinghe Commissions in 1953. This was started into a complaint by female patients, but the appalling treatment she received at Angoda. So he just reiterated that Mapata's recommendation should be implemented. And one of which was, of course, opening of the 1,000-bed Bull area hospital, which had open door policy and different atmosphere from the prison atmosphere at Angoda. So this is the modern Colombo East base hospital, which we have given as a general hospital. So psychiatrists were trained for training, and they started turning up. In 1967, we had 27 psychiatrists. I think when we retired, Kapila and I, Saman, we retired, we also had about 25, 30 psychiatrists in Sri Lanka, isn't it? So, not much an increase, but so inpatient facilities and outpatient facilities were started in Colombo, Kandy, Galle, Jaffna, and Kalutara. And then the Vikramasinghe, the WG Vikramasinghe Commission in 1966 propose a decentralization of mental health services, organization of a community mental health service, separation of forensic patients from general patients, conversion of mental hospital to an open door principle, which has not happened actually, and the revision of the mental health ordinance, again not yet happened. The lunatic ordinance of Ceylon considered mental illness as a crime. The patients are first taken to a judicial authority who decides to seek medical evidence if necessary. Revised in 1940, but did not include the provisions recommended by Dr. Professor Mapother. Then of course we had the Mental Health Act of 1956, the Mental Diseases Act. It followed some of the recommendations of Mapother, but only allowed temporary and voluntary admissions, but only recognizes the mental hospital, continued admissions to district and magistrate courts. So we have a new draft Mental Health Act. This was recommended by W.G. Wickramasinghe in 1956. We still haven't received it. College will hand over the draft version to the Health Secretary, and we are meeting him next week. I think at least in the next few years, if we can get this act together. Maybe we have a Prime Minister who has a psychosocial background, mental health background, so maybe we will be able to do something. Then I would like to acknowledge, in early 1990s, we saw Dr. Jayan Mendes appointed as acting director of Angoda Hospital, and I think this was the turning point in Angoda history, where the asylum was converted to a modern mental health institute. And Angoda now is a respectable address, as they say. But what is our future? As we celebrate 98 years, in 2 years we are celebrating our centenary, and acute admissions are coming down as many general hospitals are being opened. So clearly there's a need to develop subspecialties. We have developed quite a lot. People like Dr. Pushparan Singh and Dr. Kapila Rana Singh have been, developing addiction, LGBTQ, and various subspecialties. But we need to develop the subspecialties further. Now the subspecialties coming in. Improving services for non-psychotic patients and rehabilitation. These are going to be our mainstay. Vocational training, supported employment, and training. We are the main postgraduate training and undergraduate training for doctors and nurses. Research-wise, we are far behind if you compare places like NIMH in US or NIMHANS in Bangalore. We are far behind. And finally, to remove the vestiges, last vestiges of the asylum, we have to acknowledge however much we are proud of our achievements, we still have some issues in our hospital, which have flared up from time to time, creating bad publicity to the hospital. So I think all of us should work together to prevent violence to patients occurring in this hospital. Now I will move to the topic at hand. Sorry for the digression. And I'd also like to welcome Dr. Selvarani Richards from the Sri Lanka Medical Association of North America. They have given a very valuable donation, over 12 million to NIMH. It appears Dr. Richards is no stranger to us. She comes from the famous Babapulle family, the Kolpiti, and Kapila will remember his cousin. He was our beloved teacher in forensic medicine. And so we have lots of mutual friends who are trying to catch up. So, sorry, I forgot you at the start. So, mental health at the workplace is the start of the theme lecture. And this is an important topic because the mental health and work is intricately connected. A supportive work environment will promote good mental health and increase productivity. On the other hand, a bad work environment will worsen mental health and reduce productivity. So work and mental health is very intricately connected. 60% of the world's population are working. So out of the 60%, actually almost two-thirds are in the informal sector, not informal. Now we are all working in the formal sector, the government sector, the private sector, which have laws and regulations. But many are working in the informal sector, like cafes or cleaning services or maybe, various places which have little regulations. It is 15% of the working age population have mental illnesses. So you can realize large amount of mentally ill are in the working age population. If you look at the prevalence, anxiety is 303 million, depression is 280 million. I'm saying that because we as psychiatrists, we meet a lot of people with mental health problems due to work. And when we give medical, even in the health sector, when we say patients are having, workers having anxiety and depression, sometimes the authorities are not willing to believe that. We may have the anxiety, the depression. And even at the PGIM, I have come across this situation where people think that they are actually, they're actually conning. But the chances are the level of mental health, the anxiety and depression is quite high. And we need to support those. And as psychiatrists, I think, I don't know to tell you, we see a lot. 703,000 suicides. What is the relationship? Unemployment, loss of employment, and change in employment, extremely linked with suicide. So we all know that sudden loss of employment or factors related to employment can be a very risk factor for suicide. What is the cost due to anxiety and depression? 12 billion working days are lost each year. And $1 trillion are lost to the global economy. I don't know to tell you rupees, I will end up like late former mayor if I try to convert this. So I'll leave it at this. But of course, you must remember, the decent work supports good mental health. That we must remember. It gives a sense of livelihood, a sense of income, a sense of confidence, purpose and achievement, an opportunity for positive relationships and inclusion in the community, and a platform for structured routines. Now, we all as psychiatrists know, a lot of patients with anxiety and depression, when we offer them medical leave, they say, doctor, I will go to work. Because so there's a good working environment, and we know as some of the consultants work, doctors working in the regional hospitals also prefer, they enjoy their time in the hospital, isn't it? And going home is sometimes a burden. So that's what happens when I say good working environment. So where we look forward to Monday rather than when in Western countries people look forward to Friday. In Sri Lanka, some of us look forward to Monday. So people with mental health conditions need to work. Why should people with mental health, now we are talking about the normal population. Let's take people with mental health conditions. Actually work, that's why from 1870s I was telling you that we have been striving for that. And that's what Dr. Pushpa has been doing for last so many years. Work will contribute to recovery, it creates a sense of inclusion, it improves confidence and improves social functioning. So getting people with mental health to work at some capacity greatly helps their recovery. Now, what are the risks to mental health at work? What are the risks to? So we talked of good working environment. What are the bad things? I mean, these are all familiar to you. Understaffing and excessive workloads. Mainly for now if you take the health sector, intern house officers, junior doctors, nurses, minor staff, you all experience this. Consultants are somewhat, at least in the main centers are okay, but I think the regional centers, regional hospitals, sometimes consultants have also faced the same problem. Long and inflexible hours. Again, interns, nurses, sometimes nurses do 24-hour shifts. And I'm talking about the health sector as you can relate to it. And this is again big problem in our health sector. Lack of control over job. So that the more control you have, of course higher people have more responsibility and stress, but they also have a little control. For example, consultants have a more control rather than medical officers and nurses. So when you have lack of control, you have more stress. Poor physical working conditions, I know you all can understand, I don't want to. Limited support from colleagues. So increased competitiveness. I think even at the mental health day celebrations, the ministry people, Dr. Neil Fernand also mentioned this competitive nature among colleagues. Whereas in the army they are promoting more cooperation rather than competitiveness. But certain amount of competitiveness cannot be totally eradicated. Authoritarian supervision. Again, now many of the old schools methods are no longer valid sometimes, where the administrators and the consultants are very authoritarian. Even medical students, nursing students I can remember our medical student days, or we can remember how we were treated by the consultants, and right. So those methods have to change now with the changing of times. But I think still there are lots of this kind of thing. We have with lots of house officers, interns, nurses coming with depression, anxiety, mainly due to work-related matters. And all the psychiatrists here will know how many. And sometimes when yesterday the DGHS also commented, sometimes the Director General Health Services gives a letter recommending a transfer or something. Sometimes the local hospital director will not agree. So sometimes what the DGHS was saying that sometimes it's not worth keeping. For example, keeping a doctor in the Jaffna without totally he was depressed and stressed somewhere in Mana or somewhere. But he felt it was not worthwhile, not worth for the hospital and not worth for the person. So the current DGHS is quite flexible in that way. We have seen him being very kind and flexible in many ways. So what are the other things? Violence, harassment and bullying. And I think again in the medical profession, bullying and harassment is an endemic issue, not only in Sri Lanka, in other countries, medical profession, nursing profession, bullying and harassment. And in NIMH we are fortunate, Dr. Ranasinghe has started, Pushpa Ranasinghe has started with GBV unit. And there are, at NIMH you are fortunate because there are so many psychiatrists. But in another hospital you have nobody to go to. There are no specific counseling services unless you meet a psychiatrist who is probably going to be very busy. So there must be some institutional system to prevent violence, harassment and bullying. I can remember when we were working in overseas training in Melbourne, they used to have the zero tolerance, bullying and harassment, zero tolerance policy. So you can't shout at anybody, nobody can shout at anybody else. And if anybody shouts at them, they quickly come and apologize. Because they know that, if they create a case. So nobody can shout at another person. You can explain things, you can tell things, but you can't shout. So that's another aspect I think we in the health sector should improve. Discrimination and exclusion. Severe exclusion of discrimination of mental health patients in the health sector itself. You know that, from minor staff to doctors, those with mental illnesses, I decided to psychiatrically go to Angoda, to work in the psychiatric ward of Angoda. They think that mental ill patients should work in Angoda if you have mental illness. So that kind of attitude is still there. Changing, but still there. Job insecurity. We in the government sector fortunately don't have that. We have job security. Whether we come for work or not, we have a full job security. But in the private sector, if you work in the private sector, this has been a major problem. Tourism industry, hotel industry, a lot of people got depression and anxiety. They lost jobs, or even if they have the job, they are insecure. So job security is a major issue in the private sector, but fortunately not in the government sector in Sri Lanka. Inadequate pay is our problem. Nobody gets an adequate pay packet here. So that's consultants and doctors can compensate with private practice, but that's another issue. But those are beyond us. They are beyond us. Conflicting home work demands. So this is a major issue in Sri Lanka, ladies as well as for gents. And many are in the health ministry. You are supposed to work at wherever you are sent. So many doctors and nurses are employed far away from home. And even if they are employed close to home, working hours are such that they have to bring their children, look after their grandparents, parents, children. It's not at all child friendly. So I think we need to address this issue. I think a lot of efficiency in the health sector can be improved, in the gardening sector, if we can provide for some after school care or child care for our workers. Because many of them go off at 12 to bring their children and come back. So there are elevated risk categories in some categories, and we in the health sector belong to the elevated category. So normal percentage is 15%. I'm sure in our sector it's much more than that. So how do we, now we thought of preventing, how do we prevent mental health deterioration at workplace? So actions, what are the actions we can do? We can prevent work-related mental health conditions primarily. We can promote and protect mental health at work. And thirdly, we can support workers with mental health condition to participate in work. So there are three aspects. The first aspect, of course, is prevention. Prevent work-related mental health conditions. One would be to look at flexible working arrangements, which are now in many countries. Many of my colleagues work in Australia, they work only 3 days a week or 2 days a week. That's one reason for migration, I think, where you don't have to do private practice, you work 3 days a week and earn, and you can have a flexible lifestyle. And so we need to look into this. at least for people working in outstations, faraway hospitals. Of course, you can do shift work, but then when you work long shifts, sometimes they work 1 week at a stretch and then take leave, which is also not good for mental health. Manageable workloads. Again, with migration of doctors and nurses, this is becoming an almost impossible task. Manageable workloads for doctors and nurses. And we have a situation in the female wards or male wards. In the night, we have over 2 or 3 nurses, lady nurses in the ward, about 30-40 patients, which is not a really manageable workload. And if you take a Western country, 27 patients, 30 patients in the ward, 10 nurses, 3 consultants. But we are being held accountable to the same standards now. That's what, they expect the same standards from us. Where we have only 3 nurses for 50 patients and, minor staff will take the upper hand. So we have to be mindful of these. So as I told you, childcare support. If you can, at least that's something that we can do. If you can provide childcare support, at least for our employees, transport facilities, possibly not possible, but maybe in the private sector, but not here. And finally, to preventing of bullying and harassment, clear regulations to prevent bullying and harassment. Then we come to protecting and promoting mental health at work. And one of the main WHO recommendations is mental health training for the management. Of course, managers are also at stress, but the managers need to be able to identify mentally ill patients, mentally ill or stress and mentally ill workers, and understand about mental illness, which is very little. Even among the medical colleagues, the senior ones have not undergone training in psychiatry. And only the newer generation of doctors have some knowledge of psychiatry. Then we need to improve the workers' mental health literacy, I think, which we are doing from time to time. There are so many programs at divisional level, college level, we are division secretariats. We are doing it over the years, we have been doing it by the college and as well as the mental health directorate. Reducing stigma in the workplace, again, which goes hand in hand with improving literacy. And improving stress management skills. In that way, I'm happy that some of the workshops in this mental health day address these matters. And finally, to support people with mental illness to work, we need reasonable accommodations, flexible working hours, extra time to complete tasks, and time off for health department. And I think even at NIMH we have problems. Even with the cleaning service, we try to get people to work, but I don't think even they sometimes don't understand. We have been struggling, Pushpa has been struggling to get people employed. Sometimes we have had success with some of the private companies and where they have allowed our patients to work flexibly. But here itself we've had problems. So the return to work programs, that's people with mental illness. And finally, supported employment initiatives. So these are the cornerstones of supporting people with mental illness. So with that, I will finish my short lecture. I thank you for listening patiently.